So I am really delighted to introduce our esteemed speaker, Professor Dr. Sheila M.F. Torres, Professor of Veterinary Dermatology, College of Veterinary Medicine, University of Minnesota. Dr. Torres graduated from veterinary school in 1979 at the Federal University of Veterinary Medicine of Minas Gerais in Brazil. She obtained a master's degree at the same institution in 1982 and was hired as assistant professor, where she worked from 1982 through 1992. In 1990, Dr. Torres obtained a PhD and completed a residency in veterinary dermatology at the University of Minnesota, College of Veterinary Medicine in 1990, USA. In 1993, she returned to the University of Minnesota as an assistant clinical specialist and became board certified by the American College of Veterinary Dermatology in 1994. She is currently the dermatology section chief and full professor with the tenure at the College of Veterinary Medicine, University of Minnesota. Dr. Torres is also the vice chair for education at the same institution. She is the author or co-author of more than 50 peer-reviewed original articles. Dr. Torres is the co-author of a canine and feline dermatology drug handbook and has written 16 book chapters. She is currently working on an electronic book in small and large animal dermatology. Dr. Torres' areas of research interest are canine atopic dermatitis and alternative to conventional antibiotic therapy. Thank you. I welcome Dr. Torres. Please, now we are start with the lectures. Thank you. Esteemed speaker, Dr. Rosanna Marsella.
We are very glad to have Dr. Rosanna Marsella today with us, and I would like to just say a few words about her. Dr. Marsella is a diplomat of American College of Veterinary Dermatology and a full professor at the University of Florida. She has served as a co-editor for Veterinary Dermatology and is member of Task Force on Canine Atopic Dermatitis. She also co-edited the current Basava Dermatology Manual. Dr. Marsella is a graduate of the University of Milano, Italy in 1991. After graduation, she worked in private practice for a couple of years and decided to pursue specialty training, obviously in dermatology. Dr. Marsella became a board-certified dermatologist in 1996 and has been a faculty member at the University of Florida since 1997. She has authored more than 150 peer-reviewed articles and has written several books like Manual of Equine Dermatology and Clinical Approach to Feline Dermatologic Diseases, and contributed to many others as either author and editor. Example, the Basava Manual of Canine and Feline Dermatology. She has served as a president of American College of Veterinary Dermatology and co-editor of Veterinary Dermatology. It's not about cats and dogs only. Dr. Marsella is an avid horse lover and a proud owner too. And obviously, she has special interest in equine dermatology. She has, in fact, extensively published in the area of equine allergies, their diagnosis and treatment. So we welcome you. And without wasting much time, I would like to give the floor to our speakers and request them to start the sessions. I hope you all guys enjoy.
Here. Can you guys hear me okay? Yes? It's my pleasure to be here again, my second time in India. It's very exciting to be part of this process. I am thankful and honored to be a participant of the growth of your organization and how you are taking huge steps to improve knowledge and have increased exposure to dermatology. I was a practitioner before I became a dermatologist, so I am acutely aware of the importance of skin diseases in general practice. We have a few hours together in the next couple of days, and the bulk of my lectures are going to be on how to approach clinical presentations. In other words, it's easy to study by diseases. You know, you have a title, you have a pathogenesis, clinical signs, and so on. But I think to do the reverse, to start with the clinical presentation and think about differential diagnosis that can fit that presentation is equally, if not even more important in clinical practice, because it decides how you go about it and how you get to a final diagnosis. So my hope is for this information to be useful. I put my email address in most of my presentations. Write it down. It's my last name at ufl.edu. If you have questions, cases, things that you want to discuss moving forward, my relationship with you does not end today. It's just the beginning of a journey together. So let's talk about presentations, diseases that will affect the face. So I think many things were already kind of discussed yesterday as part of the workshop, but maybe not all of you were there. History is critical in dermatology. So you want to have, first of all, information of whether the patient is pruritic, and if it's possible that the lesions that you're observing are self-inflicted. As you do your physical exam, it is also important to identify if there are primary lesions and to make a note of what kind of primary lesions and the distribution of those lesions. So primary lesions, and this is going to be a recurrent theme, are going to be the key to identify the disease. If you only focus on the secondary lesions, the list of differential diagnoses can be excruciatingly long. So look always for your primary lesions, make note of where they are. And since we're starting with facial diseases, the first thing to ask ourselves is the face only? Is the disease also in the oral cavity? Other body parts are affected. Is the nose affected? Is the patient otherwise healthy or has some systemic illness? Because, for example, when we talk about autoimmune diseases, the bulk of them have a waxing and waning course and some presence of systemic illness. So having that information is very important. And then I kind of wrote down some examples of diseases that can fit the different presentations, just to get a starting point. So if I think of pustular diseases, in my mind, I divide follicular versus not, even if clinically you may not be able to tell the difference, but it's a way for me to remember the diseases that could fit, right? So when we talk about follicular diseases, always we think of bacteria, demodex, and dermatophytes. That kind of like you always put it down, and then you can rank based on other factors what you think is more likely or less likely. And then non-follicular diseases, examples of that are autoimmune diseases, insect bites, contact allergies, so things that basically have nothing to do with the follicle. Now, if the primary lesion is a nodule, then I think of myself, is this infectious versus not infectious? We're going to have an hour just on nodular diseases. But as a simple thing, I think of example of infectious diseases that can start on the face or that would affect the face. I think of Cryptococcus, for example. Allergic diseases, so as an example of non-infectious process, I think of mosquito hypersensitivity, because that will affect the nose in cats. And then vesicular diseases. So vesicular diseases, I think of viral diseases or autoimmune diseases. So they're big categories. And as we will see in this hour, it's critical to identify one versus the other because the treatment is completely different, right? You don't want to give steroids to somebody that has a viral condition, but you definitely want to give steroids to an animal that has an autoimmune disease. So most patients at the first visit have a secondary infection. That's just a fact of dermatology. So when we see these patients, we kind of like treat, starting with the most obvious stuff, the secondary infection. And then we reassess and see what is left. So as a general basic foundation of derm, we start with cytology. We want to know if there's an infection, what kind, the type of cells, and then if indicated, we may consider fungal culture, always recommend in cats. And if it's a dog, we most of the time would do also deep skin scraping to rule out Demodex just to make sure. And so this is kind of like the foundation, the basic starting point. Now, for different diseases, I kind of provided some examples. Of course, this is not all inclusive, but if I think of examples of bacterial infections that can affect the face, I think of mucocutaneous pyoderma. And I think it's important to remember that there are some dogs, like German Shepherds or breeds that have pendulous lips, they're prone to this. And it may look autoimmune, but it is bacterial. So again, we start with the basic stuff, and we do cytology and treat appropriately. So again, these are common diseases. It can be ulcerative, it can be severe in some patients, and it can look definitely autoimmune. Demodex, very important, example of facial disease. Some dogs may be very itchy, very red, may look like allergic, but they have Demodex. So it's critical to not miss this diagnosis and assume that any itchy face is allergy, because we may be very wrong. So I encourage people to do either deep skin scraping or a hair pluck, or squeeze the skin and stick a tape on it. You can get mites that way, whatever you choose to do, but do something to make sure that you're not missing Demodex. And keep in mind that in some patients, Demodex can actually look very different. So some dogs get red and itchy, some dogs get this gray discoloration of the skin. The reason for that is that Demodex mites plug the hair follicles. So you have a bunch of blackheads or comedones, and from the distance, these blackheads give this kind of gray color to the skin. So anytime you see comedones, whether they're on the face or on the rest of the body, think about Demodex and make sure that you don't miss it. Dermatophyte is another important consideration. It can affect the face. Matter of fact, there are some dermatophytes that are notorious for that. For example, M. gypsum is in the soil. So dogs that like to dig or at least to stick their nose in hole, going after bunnies or rodents or whatever, they can get both trichophyton or M. gypsum. So having these nodules on the bridge of the nose, think about dermatophytes. And again, like some dogs may almost look autoimmune, and think about a very important point, that dermatophytes can cause acantholytic cells in the skin. So when you do cytology and you see acantholytic cells, remind yourself that it's not every case with acantholytic cells is pemphigus. You can also have dermatophytes causing that. So very important to kind of go through your list and make sure that you check your boxes and that you don't miss anything. Submit that fungal culture to make sure you consider dermatophytes. In some cases, really can look very similar to autoimmune. That picture here on my back here, on my left, that is my own dog. I live on the farm, and he's a German Shepherd, and obviously he sticks his nose where he shouldn't, and he got dermatophytes on the bridge of the nose, but it could look like it had pemphigus, okay? So it's very important to remember that. Cats, the same. So M. canis is the most common one for kitties, and they may get it by contact. So kittens, they may get it from their mother. So the face and feet are common areas. So make sure you do submit that fungal culture anytime you have cats with skin disease. But as I said, you can also have lesions that are caused by pruritus, right? So an example of a facial disease caused by self-trauma would be a hot spot. So a flea allergic dog can be very itchy and can attack his face and cause these lesions, pyotraumatic dermatitis, in no time, okay? So that's an example of a facial dermatitis that is induced by pruritus. But cats are no less. Cats, head and neck pruritus in cats is a common presentation, as I'm sure you all know, and flea allergy is one of the most common causes for that. So the skin of the face of cats has a higher number of mast cells, so it's an area that tends to get very itchy for a variety of reasons, and allergies is one of them. So it's very important to start with the basic thing, flea control, make sure that you're not missing the big items. These specific 2 cats had flea allergy, and they caused tremendous amount of damage on their face, all self-inflicted. But cats also get other things that are linked to allergies that are not self-inflicted, like indolent ulcers and eosinophilic granuloma. So the granuloma on the palate and the indolent ulcer, most likely by epicutaneous exposure to the allergen. If you think about how cats groom, that they're very kind of aggressive groomers, and you basically, particularly if they have a flea allergy, you have that flea allergen that gets stuck on the tongue and here on the lips, and so that's a way to kind of trigger these lesions that we see. Again, some patients have both the indolent ulcer and the granuloma. The granuloma can be on the tongue, on the palate. Common presentation, again, for allergic disease. And some cats, besides the indolent ulcer and the granuloma on the tongue, they also, okay, here it is, on their chin. And that is called fat chin, or a form of granuloma, again, on the chin. So these are all facial manifestation of allergic disease in cats. Moving to dogs, I just made the list of the most common allergies that can affect the face in dogs and cause lesions, from atopic derm to contact to food. They can look clinically indistinguishable. Some atopic dogs also have conjunctivitis, but many of them do not. But the severe pruritus is responsible for the lesions, the alopecia, and they also have intense erythema. And again, clinically speaking, I cannot tell apart an atopic dog from a food allergic dog unless I have the piece of history that says the atopic dog, let's say, starts seasonal, the food allergic patient is non-seasonal. But if you don't have that piece of information, then you need to rule out food. Okay, although statistically speaking, food is not as common, but you basically cannot rule it out just based on appearance, okay? The other thing that I wanted to increase your awareness of is contact. I see a ton of contact allergy, and I cannot imagine that you have any less than me because the climate is very similar. And one distinctive feature of contact allergy is to be incredibly itchy. It's like an atopic dermatitis on steroids. Okay, so when you have these cases, they're 10 out of 10 itchy, they're demolishing their face, and they're not responding to whatever drug you are selecting, think about contact. So this dog was referred to me as a non-responder. So they tried the Apoquel, the steroids, the cyclosporin, it was not responding. And so anytime you have anything like that, think of contact. And if you looked at the belly of this dog, then you realize that the atopic derm doesn't do that, okay? So if you take a closer look at the edge of these lesions, let's see if I can do this better this time. Okay. It's not. What did I do? Master this. At the edge of the lesions here, you see the papular eruption, right? And then in the center, they all coalesce together. Okay, so papular eruption, think of contact allergy, okay? So the features are all the areas are not protected from by the hair and an extreme pruritus, okay? So this dog had contact allergy. This one had contact allergy. In this case, it was to the food bowl. The previous one was to plants. So based on the distribution, you can kind of think of what the trigger is, but the distinctive feature is the intense pruritus that does not respond to treatment. And you don't need to be a dermatologist to diagnose these cases. You can ask questions on what is in the environment, where is a carpet or plants that they have in the yard. Ask them to bring samples and then do a patch test. And the way we do a patch test is that, let's say the plants, you will chop the plants, the leaves in small pieces, put some KY jelly to kind of like keep it all mushed together, and put a patch directly onto the skin, leave it in place for like 24, 48 hours, then unwrap it and look for the lesions. Okay, so that's what we do. You know, again, you don't, yes, educate me. So this, you prepare your own allergens, right? You don't have to purchase anything. And again, it can be the carpet, it could be the plants, it could be anything that you suspect could be a culprit. And the lesions, when you pull the patch, is this primary papular vesicular lesion, okay? So, and there is no treatment that you can do other than avoidance. You cannot do immunotherapy for contact allergy, okay? So you just need to identify the trigger and remove the exposure. These are some pictures of plants that I see in Florida, commonly responsible for contact allergy. I suspect you have some of those. I think particularly the purple one. I believe I've seen those here. And very, very common, very allergenic. Okay, this dog, they brought it to me for euthanasia, but I'm a sucker, so I said, no, I don't want to kill this dog. So I took him home. I had no idea what to do, but the point is, I don't have carpets in my house because I live in a log cabin, and this dog was allergic to carpet. So here it is. So think about any time there is something that doesn't make sense, right? So hit pause and regroup. But the bottom line, contact allergy is very itchy, and it will fail treatment. Because if you have, let's say, poison ivy, and you sleep on poison ivy every night, there is no prednisone that is going to save you, okay? All right, now moving to a different category, autoimmune diseases or immune-mediated diseases that will affect the face. I kind of made it a short list, from pemphigus to discoid lupus to VKH and others. So let's go down this list and see some examples of it. Pemphigus foliaceus, the most common autoimmune diseases in small animal, actually in large animal too. And it starts on the face in most cases and has this butterfly, they call butterfly appearance. So it goes around the eyes, the bridge of the nose, and the nose itself. The primary lesion is a pustule, but the pustule is transient, so you just have a bunch of scabs, okay? So a bunch of crusts is a crusting disease that affects the face, okay? No lesions inside the mouth, just the skin. And they can get very sick, very depressed, stop eating. So these are all examples of pemphigus foliaceus, right? So your cytology will basically give you a clue. You look for acantholytic cells, and you want to establish if it's an infection or not. The only thing that could remotely look like this is dermatophytes, okay? Bacteria typically don't do this, and dermatophytes will not make you systemically ill, okay? The poster child for pemphigus foliaceus is a middle-aged animal, okay? So, and again, it's not just the skin, it's also the nose. So you will have this crusting, these pustules that crust over, so this crust on the nose itself. Cats also get pemphigus foliaceus, and they have it on their face, their chin, ears. Sometimes they are referred for refractory chin acne. So if you have cats that you think is chin acne but is not responding to treatment, think about pemphigus foliaceus, right? Again, you do your cytology, you look for the acantholytic cells, and I encourage you to take a biopsy because there are other diseases that can cause acantholytic cells. Now, different type of pemphigus. Pemphigus erythematosus is like a PF limited to the face. Okay, so it's typically the nose, sometimes around the eyes, but primarily the nose. And it's aggravated by UV exposure, so that's important to remember because it's part of treatment that you want to avoid UV exposure. And it kind of like it varies in severity. In some dogs it's very mild, in some dogs it becomes severe. But the thing is, you have these crusting lesions, again, the bridge of the nose and the nose itself, and you can eventually kind of start having ulcerative lesions. Okay, so that you start having more aggressive, deep ulcerative lesions if it's uncontrolled, like this one. So even if it's localized to the nose around the eyes, for this patient, the lesions were clinically severe. Okay, so you can have something severe yet localized. And eventually you kind of lose the architecture of the nose and it becomes deeper and deeper, more severe and ulcerative. You have depigmentation as a secondary change because of the lesions getting deeper. And this is something to kind of keep as a differential diagnosis. Now, if I have a dog that besides the nose also have ocular disease, I think about another disease. It's called VKH or uveal dermatological syndrome. And in this disease, there is an autoimmune attack on melanocytes. So it's a different mechanism. It's still an autoimmune disease, but it's a different mechanism, and this is why you have ocular involvement. So there are some breed predilections for that, and it's very important to have a prompt diagnosis because these dogs go blind. And so it's very important to kind of diagnose them and treat them aggressively to save their eyesight. If you don't, you end up having to do enucleation like we had to do in this dog. So again, you have depigmentation, you have ulcerative lesions, and you have also ocular disease. Now, there are other diseases that can affect the face that are immune-mediated but not autoimmune. So one example is vasculitis, okay? And I see a lot of vasculitis many times linked to a vaccine. And that's something important that I encourage you to do. Anytime you see anything like vasculitis, pemphigus, erythema multiforme, ask yourself, is this, quote, idiopathic in the sense I don't know what triggered it, or is this triggered by vaccine or drugs? It's very important. Anything that was given to the patient in the 4 to 6 weeks prior to the development of lesion is a possible trigger. And it's important to identify that because that increases your chances to give a better prognosis to your patient. If you resign to the fact that it's idiopathic and you don't stop that drug or you don't avoid that vaccine in the future, you are basically decreasing the likelihood of giving a good prognosis to your patient. So this one, vasculitis, it was secondary to Bordetella vaccine. And so again, facial disease around the eyes. So if I look at this dog, I cannot 100% say, right? I mean, it could be erythema multiforme, it could be another autoimmune disease, I really don't know. But then if I see a patient that has lesions also on the tip of the ears, I said, okay, I got this. Okay, this is most likely vasculitis. Vasculitis is a type 3 hypersensitivity. You have antigen-antibody immune complex apposition, and they end up getting stuck in the smaller vessels. And so skin-wise, we're talking the tip of the ears, on their feet, the toes, tip of the tail. Those are like key points to check, okay? And then as a comparison, you can have other vasculitis or a vasculopathy. So vasculitis is when you have an inflammatory process that targets the wall of the vessels. So it's inflammatory, and it's most of the time acute. And the lesion can be more or less severe depending on how deep the vessel that it was affected. Like this foot is very bad because it was a deeper vessel. So the whole area that basically was depending on that blood vessel went necrotic. And so you have a big scab, and then it falls off and you have a hole, right? But if you have a vasculopathy, that's more of a chronic disease. And dermatomyositis is a prime example of that, where you basically have more of a scarring dermatitis. Okay, so again, now we're kind of moving to a different group of diseases. So it's a vasculopathy still affecting the face. Okay, so dermatomyositis is an immune-mediated disease, affects both the skin and the muscle. It runs in certain breeds, in certain family, and it can start very young. So that's the difference. So pemphigus foliaceus is a disease of middle age. Dermatomyositis is a disease of young individuals, okay? So that's kind of like, mentally as you rank your differential diagnosis, think of the segment, right? But these dogs basically get vasculopathy, so they have facial scarring disease as well as the tip of the tail that is affected, so then you know it's a vascular disease. Okay, and they get this basically non-inflammatory alopecia, encrusting, and scarring facial disease. Okay, so that's kind of like different pictures, but basically the same process, different from your pemphigus foliaceus pictures, right? That is more pustular, crusting, inflammatory. Okay, now there are other immune-mediated diseases like erythema multiforme that can affect the face. So erythema multiforme is a disease in which you have individual cell necrosis in the epidermis. So it's a type 2 hypersensitivity, it's a cytotoxic reaction, and as a consequence you have this individual keratinocytes that die at different levels in the epidermis. So as a consequence, you have first the erythema, and then you have ulcerative lesions. So this was an example. It started on the face and the lips, but when I look on the side, I see these macules. They're target-like lesions, and that kind of increases your chances of erythema multiforme. That's kind of like a classic pattern where the edges are red and the center is a wider color. So they call it target lesions. And so the question is, what's triggering it? So erythema multiforme is not really a diagnosis. It describes a clinical syndrome. Then as a clinician, once again, I have to ask myself, why? Is it a drug? Is it a vaccine? What is it that is making this patient develop these lesions? Now, another form that is immune-mediated, but like making it a little bit more severe, is toxic epidermal necrolysis, in which the necrosis of the skin is not just individual cell necrosis, but is full thickness necrosis. So the skin literally sloughs. And again, it's a reaction to a vaccine, to drugs, and it's critical to figure out what it is, because if I cannot identify it, then these patients will die. So mortality is 80–90%. And the skin, it becomes so fragile that if you run your finger, the whole thing kind of like, you can slide it and have all the skin peel. And that is called Nikolsky sign. So basically, they get extensive ulcerations, not just on the face, but they can be all over their body. Now, other diseases that are autoimmune that affect the face and the oral cavity, we have bullous pemphigus and pemphigus vulgaris. I lumped them together because they look very similar, even if the antigen is different, but clinically speaking, you have bulla and then you have ulcerative lesions starts in the oral cavity. So this is critical. Remember, pemphigus foliaceus, I told you, is on the skin only, not in the mouth. This one starts in the mouth and is ulcerative, is much more aggressive. So very important to have a prompt diagnosis and treat these patients to improve their survival. Now, if you want to read about all the different autoimmune blistering diseases, there are many nice publications out there where you kind of can learn about the different antigens and the different names and so on. I kind of lump them all together because I think, honestly, the treatment is always the same. Regardless of what the antigen is. So and the diagnosis, you always go the same way. You take a biopsy, and you always go the same way. You avoid an ulcer. It's never useful to biopsy an ulcer because the bulk of these diseases are diagnosed either in the epidermis or at the junction between the epidermis and the dermis, basement membrane. So ultimately, you want to biopsy a macule, but never an ulcer. Okay, so I think this is a critical take-home message. Okay, now other diseases are very peculiar that you may see is the arteritis on the nose. This is also an immune-mediated inflammation of blood vessels, but at this point it's the artery that is affected. It's not a vein. Large breed dogs are prone to it. And they can bleed like uncontrollably, and that scares owners. So they come as an emergency, right? So they have, and this, look at the clinical feature. The bulk of them are right in the center, right? And so that is your take-home message. You know, when you see anything in an ulcer that looks like this, there is no other differential diagnosis, okay? Sometimes, however, the ulcers are bilateral on both sides. Again, the history, the breed, the fact that it's bleeding uncontrollably will increase your diagnostic suspicion that this is a nasoarteritis. The treatment is immunosuppression. So whether you want steroids versus apoquel versus pentoxy or cyclosporin, is individual preference. Most people would use high doses of steroids with pentoxifalline because pentoxifalline is used for vascular diseases. But again, the bottom line, you want to have some form of immunomodulation. Now, other diseases that can affect the face, one that is very characteristic, very different from anything I've discussed so far, is juvenile cellulitis. Okay, the presentation here is a young puppy most of the time. I've rarely seen it in older individual, but I've had a couple of cases that were 1-year-old or 2-year-old, but that's exception. Majority of them are young puppies, and they get this pustular eruption on the pinna, on their face. They're sick. Puppy strangled, they have lymphadenopathy, and this is an immune-mediated disease. It's very important, however, to make sure that you don't miss Demodex, because Demodex can give you pustules, can affect young animals, can give you a lymphadenopathy, and if you start immunosuppressing a puppy with Demodex, assuming that it's puppy strangles, then you're going to make things worse. So again, however you want to rule out Demodex, make sure you do, and then the treatment for this disease, again, is immunosuppression, okay? So most clinicians will also add an antibiotic, even if it's not a bacterial disease per se. That is just, it makes us feel better that you're kind of covering for secondary infections. Other diseases, peculiar, that will affect the face, herpes, right? I'm sure you've seen many of these kitties in practice. They may have respiratory disease, ocular disease, facial disease. So again, it's kind of like something that affects the face and is viral, may look autoimmune, but is viral, okay? And so that, again, is why it's critical to make that difference. If I see this nose, I could say, mosquito hypersensitivity, let me reach for some steroids, right? But again, you know, it's important to consider the history. Do I have other signs? Do I have respiratory disease? Do I have ocular disease? Do I have anything to make me feel that it could be viral versus allergic? And you can take swabs to isolate the virus, or you can just do a biopsy. to kind of like make sure that you have the right disease, and then you can prescribe the appropriate treatment. So the appropriate treatment, depending on what you have available here, which I don't know, but it's an antiviral of different kinds, depending on what is available to you. Now, infectious diseases that will affect the face of a cat, I thought of crypto is kind of a classic example, right? But Cryptococcus, the infection is by inhalation primarily. So when they develop nodules on their face, it's typically a manifestation of disseminated disease, right? So that's very important. So it's not just about the nodule. It means that they have Cryptococcus as a disseminated disease. Okay, and it can be very aggressive. They can have disfiguring lesions. Typically, they have some systemic signs, particularly when you get to this point. But another disease that can affect cats is sporothrix. And in this case, the infection is through the skin most of the time. And they get a cutaneous disease, and then this disease, it travels through the lymphatic and can become a disseminated disease. Cats typically have a ton of organisms in their lesions. Why is this important? This is a zoonotic disease. So anytime you see a cat that has a nodular lesion and is draining, reach for a set of gloves, because we all have little cuts on our hands, and so if you touch it and has a lot of organisms, then you're going to get sporothrix on your hands. So cytology, once again, is the way to go, right? So you want to know, first of all, is what kind of inflammation it is, right? Do I have eosinophils and I think of allergies? Or do I have neutrophils and macrophages? I think of infection. And if I have macrophages, do I have organisms in it? I put these two slides together side by side. Sporothrix is a little bit smaller than Cryptococcus. Okay, and Cryptococcus has that nice thick capsule. But so again, these are diseases that you can diagnose with the simple cytology so that you know it's fungal. Now, but I also mentioned you can have allergic diseases that affect the face, right? Mosquito hypersensitivity is a classic example. Mosquitoes like to bite on the nose and the tip of the ears and feet of these cats, and so cats that like to be outside, particularly in the evening, are prone to this. And then the lesions rapidly progress to ulcerative lesions, because think about these eosinophils that degranulate. And that is very toxic for the tissues. That's why you have all this degeneration of the collagen and these toxic lesions. So they are both itchy and painful, and they can have these disfiguring lesions. And your cytology will give you a sense of direction, because you're going to find a lot of eosinophils in your cytology, and that in conjunction with your history increases your suspicion that indeed is mosquito hypersensitivity. The ears are also frequently affected, sometimes the feet as well. So the treatment is many times steroids to decrease the inflammation, and then you need a repellent. So the two things to consider are, one is neem oil, which is safe for cats and is an effective repellent for mosquitoes, or catnip. Catnip is also a repellent for mosquitoes. But dogs can also get eosinophilic furunculosis. So particularly dogs that like to dig and stick their nose where they're not supposed to, they can get fire ant bites. And so the lesions are very pruritic and painful, and they develop quickly. So the classic history is a dog that is left unattended in the yard, and then when it comes back inside has this rapidly progressing lesions. They start with little papules and pustules, and then before you know it, you have this swollen, necrotic, ulcerative lesions, very itchy. Cytology, once again, will tell you it's full of eosinophils. So that, in conjunction with the history, you don't need a biopsy, right? You have your diagnosis. But other things can also cause lesions on the face. In Florida, we have spiders like brown recluse and black widow, and they're they induce rapidly progressive ulcerative necrotic diseases. And so that's something to keep in mind. Both of those diseases, you want to reach for steroids, whether it's mosquito, fire ants, spider bite, you want to halt that aggressive inflammatory response. So high doses of steroids, at least for a few days. Now, moving to a different category of diseases, yesterday we had a patient that came back with a high suspicion of MF, so whoever was in the workshop probably can relate to these pictures. So depigmentation on the nose of all dogs is something to take seriously because it's one of the manifestations of cutaneous lymphoma. And again, think about this nose, particularly if the history is the nose used to be black and now has that kind of gray discoloration, and then eventually they get scabs and they get ulcers, and then you look in the mouth and they have that distinct gingivitis. But the teeth, they look good, or they just had a dental and they still had that gingivitis. So think about cutaneous lymphoma. So this is a lymphoma that has tropism for the gums and the skin and can affect the face. Okay, so inside the mouth and then on the nose and the lips. Some dogs will get the plaques and the nodules, makes it easier to kind of think about it, but some don't, at least not early on. So all you have for a while is just the depigmentation and the crusting. And then some will just have other manifestations. Some they just turn red, itchy, scaly, silvery scaly. And so different presentation. We'll talk more about lymphoma in the next couple of days, but this, I wanted to show you that lymphoma can affect the face, and so you need to think about it. Other neoplastic disease in cats, that can affect the face, ears, of white cats that like to sunbathe, is squamous cell carcinoma. So that's another differential diagnosis for facial disease in kitties. And then you can have benign diseases. You can just have animals that just have a crusty nose because they have primary disease of keratinization. That's who they are. Crusty feet. It's a benign hyperkeratosis, and there's no treatment. You just want to keep it nice and conditioned, with some emollient, some cream or something so that it doesn't crack. But it's like there is nothing to worry about. So to conclude, there are many diseases, as I've described, that can affect the face, the nose, and sometimes inside the oral cavity. And so it's very important to have an accurate history of drugs, the age of onset of the disease, whether there are primary lesions or not, and what kind, what is the distribution, and whether the patient is systemically ill or not, so that you can kind of rank your differential diagnosis and kind of start ruling out simple things first and then go down your list. I encourage you again to go for simple things first to make sure that you don't make mistakes. And then once you have ruled those out, many of these diseases I described to you eventually need a biopsy. And so you want to biopsy an area that is not ulcerated so that you have the highest chance of having an answer. So this is what I had for you on facial diseases. I have no idea of time. Hopefully I have time for a question. Do I have time for a question? Yes? Okay.
This is about hyperkeratosis. Do we only see it on the nose, or we can also see it at other places, at other mucous membrane areas?
I would say nose and feet are the most common ones.
Never on perianal areas?
I have seen those too.
Yeah, that's because I've actually seen that, so that's what I was asking.
I have.
Yeah, okay, thank you.
Some reactions to the vaccines. You have done some work on the particular types of vaccines, because here we do a combination of vaccines, so we are actually not able to sometimes understand. And then since the vaccines are only repeated annually, so you do have data or statistics supporting which vaccines actually give more of reactions, or if you can say some brand names or whatever, if you can.
Yes. So rabies is notorious for vasculitis. So that I can tell you for sure. And you can have vasculitis at the site of injection, and that is particularly common in small breed dogs like little poodles or Yorkie, that they develop this alopecia spot at the site where the vaccine was given. And, but other dogs will develop vasculitis in a more generalized fashion, not just at the site of injection. So for sure, rabies. The other one that I've seen a lot of vasculitis, and Dr. Torres can help me here, is Bordetella. Bordetella, which I don't know why, you know, so it should be a fairly benign vaccine, but I have seen quite a few getting that. As a general thing, and you know, I understand that vaccines can be a loaded topic right now, but I used to consider vaccines a benign thing, but I've also now seen patients die from it. I've seen 2 horses die from vaccination. So I now kind of always consider the benefits and the risk of the vaccine, the lifestyle of the patient, and I also encourage people to not use this 5 vaccines at once, 7 vaccines at once, to possibly give it separately, to kind of, if there is a problem, to identify what it is, and also not to overload the immune system. And so I think over the years, I have kind of changed a little bit my approach to vaccinations. If I have a patient that is strictly indoor and never leaves the couch and never goes anywhere, it doesn't go to the dog park, it doesn't go outside unsupervised, has, you know, basically you are inside, and then maybe it does not need to have this rabies vaccine every year or all these vaccines. Particularly if has already had vasculitis at the site of the injection. So now I go by case. But to answer your question, I can safely say rabies and Bordetella.
Thank you.